want to give a very brief introduction to what we're trying to do here on the Physician Innovator. Innovation is just this huge, huge field, but our interest is in a very particular form of innovation. Innovations that take the form of a small but full-time clinical team. Full-time or very nearly full-time, that redesigns care and delivers better care for a specific patient population. As I said, innovation is a huge, huge universe, so you may ask, why focus on this particular form of innovation? And there's some good reasons why. Number one, these innovations are very powerful in that they deliver so often a double win. That is, better outcomes for patients and simultaneously lower costs for the system. Like penicillin, like a cheap and curative pill, except that it's so rare in this day and age for the biosciences, innovation in the biosciences, to deliver that double win. We're far more accustomed to improved outcomes somewhat, but at a great cost to the system. Here we're talking about innovations that deliver the double win, better outcomes and lower costs for the system. Another difference is when you talk about innovation in the biosciences, you're talking high tech. You're talking the cutting edge of science. Here on this platform, we're talking about innovations that are grounded in straightforward principles that you've talked about and thought about, no doubt, already. Things like coordination of care, prevention for patients that are at high risk, standardization of processes where it makes sense to standardize them, careful medical decision making. These are the types of things that we'll be talking about here. You don't need rocket science to get the double win. We're also talking about innovations that aren't enormous gambles, and in fact, they're very modest risks. We're talking about small clinical teams. Today, we're talking about a team of 3 plus or minus, how you want to count them, but 3 people that are focused very much full-time on a high-risk segment of the population, or the patient population. So we're not talking about big risks or big investments at all. We're talking about innovations that have been overlooked for a long, long time, for decades, I would argue, precisely because, or mostly because, of our payment system and the ways that it gets in the way of this form of innovation. And I like talking about this form of innovation because literally there are tens of thousands of opportunities for this form of innovation in the United States alone. Very worthwhile. All we're trying to do here on the Physician Innovator is to create a platform for sharing insights and experiences among the clinicians, and they're mostly physicians, who are leading these efforts. And that gives me a chance to introduce our guest today, Stuart Pollock. So Stuart, I'd like to start just by having you help us walk in your shoes for a second by asking you to describe sort of present day reality in your clinic. What is taking up most of your time this week or this month?
So most of my time is actually patient care. I actually practice, I mean, technically it's 5/8 of time. The patient care, it depends on the week. I actually pulled my schedule out. I start patients at 1 o'clock for today, and this afternoon seems to be the afternoon of the bipolar polysubstance abuser. That is, there's actually 4 on the schedule. That's actually not normal. It's sort of a high amount. In the clinic, what's taking up my time, honestly, is we had a physician move to California to enjoy the better weather and stay married. Yeah, don't hire clinicians whose husbands are cancer immunologists. Apparently they're very much in demand at the moment. And the docs are not starting until September. So a lot of what is in my mind is how do I take care of an extra, 1,800 patients, and ask the patients to be patient while they wait for the cavalry to show up.
Well, sounds like very real problems that I'm sure many of the people on the phone can relate to very directly. How about thinking just a little bit longer term, Stuart? What's most pressing for you in terms of what you'd like to accomplish over the next, year or two, let's say?
So I actually said this last year. I declared last year as the year of patient activation. So this year is also last year actually became the year of the new electronic health record. This year is still partially learned to use the new electronic health record, but I think patient activation is one of the things I don't feel we're really good at. We're not going to solve the group of patients that don't. There's a group that sort of fail the model, and a lot of that is activation.
One of the things I learned from our interview some time ago now is that you've managed to become known as the clinic in your area that is particularly good at dealing with the most complicated patients. How did that come about?
It's actually this combination of medically complicated and psychiatrically complicated. So behavioral integration is not considered that cool anymore. Everybody knows they should be doing it. But 6 years ago when we started planning the clinic, we were a little ahead of the curve. And so when we opened the practice with 3 social workers, word sort of quickly spread. Part of being primary care in an academic medical center is a little bit different. A lot of our referral base is actually specialists at the medical center, and word sort of spread that if you had a patient who wasn't showing up for their chemo because they were psychotic, that we were actually pretty good at that.
Did you have these patients in mind from day one when you decided to build the clinic?
Now, we actually did a really poor job of understanding our population. I mean, we knew where we sat physically. We knew that the neighborhoods were, very diverse, that we sit between a very rich area and an area of large public housing. But I don't think we did not understand how complex our patient was when we were planning the practice. And I think if we had, we would have planned it slightly differently.
What is the biggest surprise along the way in terms of understanding your patient population?
Again, I think it was just the medical hits psychiatric. I was, when we added the 3 social workers, the thought was that the social workers would actually be a more price-efficient way to deal with, diabetics who are not activated. It's just a social worker in Boston is actually significantly cheaper than an RN in Boston. And then it turned out, lo and behold, that we managed to keep all 3 busy with behavioral health. I think one of my shockers is when you actually, obviously if you have the resources, then you go looking for it. When you start looking for behavioral health problems, it's amazing how much is out there that has just been ignored or swept under the rug.
You've said that one of the key assets on your team is the nurse care coordinator, Caroline Melia, and she came from Boston Healthcare for the Homeless program, at least some ways back in her career, I suppose, an organization I got to know a little bit as well. Would you say there's a lot of overlap in the characteristics of the 2 populations, the homeless population and the population that you deal with, the exception, of course, being homelessness?
We actually do take care of homeless, but only if we think it's temporary. If they're going to be long-term homeless, we actually try to move them to Boston Healthcare for the Homeless because they're really good at what they do. It's another great example of someone with a very focused mission, with sort of a great team. But they, certainly a segment of our population, the high risk. It's this combination of sort of psychiatric problems, medical problems, and chaotic lives. Caroline has always argued that one of the best predictors of readmission risk is when you call the family at home, how many people are screaming in the background. So, if there's 3 or 4 more people screaming in the background, you're in a lot of trouble.
That's interesting. One of the things I picked up from the questions that people submitted in advance of our talk today is that, primary care redesign is this huge topic that spans lots of different types of populations. And I know you had a chance that you appreciated to do some studying and thinking before you launched this clinic about primary care redesign. And I'm wondering if there's other initiatives out there that really impress you in primary care redesign but are quite different from what you're doing.
I like to think we sort of stole the best ideas from everyone in the country. I think, there's a lot of, my background is actually not in an academic medical center. It's in the world of sort of integrated healthcare systems. And then, there are groups that have been good at this for 80, 100 years. They're just, the exception, not the rule. One of the cool things about coming to the Brigham is you also realize that there's a whole network of community health centers that do this very well, and there's actually a network of the VA that does this very well. I think one of the things I've come to appreciate is, this idea that I think we all know we have to segment our populations. Is that there's pretty much always someone who has segmented your population and played with them for a while that has something to share. You just have to find them.
True. It's one thing to segment the population, quite another to match a team that is perfectly suited to serve that population. One example that one registrant brought up in advance was the example of Iora Health that I think came up in our conversation as well. Talk about how your approach differs from what they're doing and how the populations differ, if you would.
So we spent a lot of time talking to Iora. The head of Iora used to be at Mass General. We've talked to them about behavioral health. They've actually shared quite a lot about coaching. I think the classic Iora population, and they're scaling now, so it's more than one, is sort of, what I think of as sort of high rising risk, sort of multiple chronic uncontrolled diseases. And we do that because, we take all comers. If you call, you can book it, well, probably not right now, but if you call in a couple months, you can book an appointment here no matter what. I think we're good at that. They actually might be a little better. I think we're better at, it's sort of, I'm already bouncing in and out of the hospital. That you're actually achieved a high risk or even super utilizer risk.
So I want to dig in a little bit into exactly how your clinic operates and simply understanding the team that's in place. Perhaps this was in the article and people have read it, but let's make sure everybody's got that top of mind. You have 3 teams that see patients every day, and then a standing team that deals with high-risk patients that you were just talking about. Can you give us a little bit more color there?
Right. So we have 3 teams. Each team is one full-time equivalent of physicians, frequently made up of 3 physicians. So I have a lot of quarter-time docs. I'm an academic medical center. Each team has a full-time physician assistant, an LPN, and that's kind of a uniquely Brigham thing. Most people would use an associate's RN, 2 medical assistants, and a social worker. And then each of the teams shares a pharmacist, a nutritionist, an RN care manager, and this person comes and goes, but a population manager, and came and just started again a community resource specialist. And then they clump themselves into teams. So in many ways, the diabetes team is the pharmacist and the nutritionist. The high-risk team, in many ways, is Caroline. It's the RN, and then, if it's the high-risk drivers of behavioral health, she'll pull in a social worker. If it was diabetes out of control or med adherence, she would pull in the pharmacist. And then it's pretty much always end up with the physician, and usually the LPN on the team, because honestly, if you call and you're sick, that's who you're probably going to end up with. And so they need to know what's going on.
Stuart, so the 3 teams that have a full schedule every day of patients, I'm imagining them sort of on a hamster wheel. It never stops. How do they have time to have effective conversations with Caroline Melia, the nurse care coordinator, or your pharmacist, or your nutritionists, so that you have true teamwork going on?
So we run on a 20-minute block instead of a 15-minute block. So when we opened, we actually opened with the doc could choose 15, 30, 45, and 60. What we figured out is that no one needs 60 minutes with a physician. If you're that sick, you actually need a team. And that honestly, very few people needed 15 minutes, and part of that is the population, and part of that is, if you're going to come in with an ankle sprain, I'm going to talk to you about your mammogram. So that drives it a little longer. So, if you're running a 20-40 minute block, which is what we do, you're actually only seeing 8 patients in 4 hours on average. So that actually creates a little bit of time, especially when you toss in the medical assistants are probably doing about 7 minutes of work when they put the patients in the room. The huddle, we've always huddled. And so that's part of it. The huddle, how we huddle seems to change constantly. We sit people next to each other. So we it's one of my theories about effective teams is you just want to build an environment where people talk to each other constantly. So we make that easy by co-locating. And then honestly, we close the clinic for 2 hours on Wednesdays from 1 to 3 p.m. So that people have time to deal with, sometimes, actually about a third of that time is patient care, and a lot of the time is to deal with the process issues.
There's about, I don't know, a quarter perhaps of folks in the audience today that have taken a class with me or heard me speak, and they know that slack time in the schedule is so crucial to make teamwork happen. Anytime there's a combination of a full-time team, Caroline and the pharmacist and the nutritionist, needing to interact with people who are only able to engage with them some of the time because they have so much else going on. So I just wanted to highlight for the audience that choice to deliberately create slack for the non-full-time members of the team is, in my point of view, a really important piece of the culture that you've created there. But let's talk about that culture you've created a little bit more broadly. I know this is something that you've given a lot of thought to. You're trying to create a culture of teamwork in an industry with such a strong individualist tradition. Talk to me a little bit about what you and your co-leaders have to do to bring about that kind of change.
So it's, I can go on for hours about this. I'll be careful. Part of it is when you know you're doing it ahead of time, when you've thought through your culture ahead of time. We actually are a startup. We're a 5-year-old startup, but we're a startup. You can hire for people who will do well on a team. So we had a very specific behavioral interviewing strategy. Most of the questions which we actually continue to use 5 years later to get people who like team. So a lot of the question is, where do you find your physicians to do this? And to some degree, we're a cheat. You're not here if you didn't drink the Kool-Aid. You believe in teamwork. It's another advantage of having a lot of the part-time physicians. A lot of my docs actually live in various parts of the innovation world, as entrepreneurs or as researchers or as leadership at the hospital. So that's been easy. Honestly, most people, I tell people that, or I tell doctors that, most of us didn't run cross country in high school. Most of us played soccer or football and baseball. That, generally team is more fun. So that makes it easier to sell.
One of the things that you've experienced that's pretty unique, at least as far as I've seen, is so many years spent on either side of the fence, capitation on one hand, fee-for-service on the other hand. Certainly there's a huge cultural difference on either side of that fence, and you're trying to push your group towards that sort of quadruple aim, as you called it, kind of culture. Talk a little bit about how you created an environment where everybody's thinking about all those competing objectives.
So it's it's interesting. I say we plan the culture. I realized a year or two ago that we forgot to plan the mission or the vision, and actually we didn't plan values. I think luckily in planning the culture we got sort of a set of values that there's just a sort of understanding we're here to take care of patients. We're not in the visit business. Luckily very few people put, and we as an organization do not pay pharmacists or nurses on volume. They're salaried. It's only the physicians who are paid on volume, so they don't have a strong financial incentive. And while it can be very stressful to say, I'm in the business of taking care of human beings versus being in the business of doing visits or taking care of livers, obviously it's much more fulfilling too.
Taking care of patients across so many different stages that they might be going through, from hospitalization to discharge to a rehab facility to a long-term care facility to their home. Certainly one of the times you have to be particularly attentive to is those transition phases in and out of the home, in and out of the hospital. Can you talk a little bit about how your team organizes to exert extra effort at those critical moments?
So when we opened, obviously this is not the world's cheapest model. So you had to ask yourself, what can we do for the Brigham? And one of the things we figured out we can do for the Brigham is you take patients that are basically not dischargeable or can't go home from the emergency room because they don't have a functioning primary care relationship. It's interesting in the land of Romney care, even 5 years ago, pretty much everyone is insured. And so you get this population that is, they're insured, but they have been unable to access the system, usually because this is where you get into a lot of the psychiatric stuff. And so when you go to the hospitalists and the house staff and say, yeah, just send it, who you can't discharge home because they don't have a PCP, you all of a sudden discover the volume is huge. I mean, obviously Brigham is a huge hospital, and it's actually, there's this community hospital a mile away, but there's just a lot of people in that situation. So then you have no choice but to build the process. So the first thing is obviously, you just can't put it all on the physician, and honestly it wouldn't go with our culture. And so we sort of, we started with Caroline, who sort of knew this business because of her other nursing positions. We actually put together a group and we did checklists. We were smart enough to rip off from Atul Gawande and put together sort of a checklist with a process, which looks a lot like the Coleman stuff from, I think, Denver, Colorado, because we're big borrowers. And the original process actually had the nurse going up to the hospital and meeting the patients before they came, and then we quickly realized that that was more time than we could put in. But it's a phone call to their hospital bed. The goal was to see them within 3 days, because if you actually look at readmission curves, they kind of go like this, right? It's not like people don't start getting readmitted at 10 days or 14 days that people use. They come home, they're basically at risk. So get them in quickly. A lot of this is, one of the biggest problems around admissions and readmissions is meds. So, hey, we have a pharmacist, right? So let's book a visit with the pharmacist doing the med rec because she's better at it than I am. And then let's bring in the physician to do the medical issues. And then, follow up with Caroline. If it's complicated, with the physician, if not after the physician, to take care of, all the care coordination issues. And it worked well. And then it's just the problem is we never could actually meet the demand.
Yeah, and so certainly to make all of this work well, one of the things you have to do is build good relationships with, say, rehab centers or nursing care centers, home care organizations. How have you gone about that? Do you have a few perhaps that you have particularly good relationships with?
So we Partners owns its own home care agency, but it was one of the first neighborhoods we did. So, we're a medical home, so we have a medical neighborhood. I always say that terminology is probably not ideal, but it's kind of what won. And I think when we opened, we thought our medical neighborhoods were going to be cardiology and pulmonology. But it turns out probably, the useful medical home neighborhoods have actually been psychiatry and geriatrics and the home care agency. It's really interesting. When you reach out to your home care agency, no one ever calls them. They're the most lonely people in the world. So we talked to somebody, and then we actually got partners to agree, at least in the areas where we had a lot of patients, to give us a dedicated nurse. So we pretty much only work with about 4 home care nurses, except they're on vacation. And so you build up a trust thing. I always joke that one of the things I learned when the nurses came and actually met the doctors, and so few doctors ever meet the home care nurses they work with, is that one of the hardest parts of being a home care nurse is where do you pee between patients? And saying, hey, you can stop by and use our bathroom whenever you want. And while you're here, chat with me. It's very civilized.
Do you have sort of routine, rounding conversations with these 4 nurses or so in various organizations nearby?
So now it all funnels through Caroline. It's just, she maintains the relationship. And then, the Partners Home Care started a great program where they would send an NP out to a house emergently. And as soon as that became available, we got to meet the NPs. It was about 2 years ago. I think we're their biggest source of business. And it's really worked quite well. So, I think with everything, there's a question of do you do it yourself or do you partner really well with somebody?
Stuart, we're at about the halftime mark. I'm enjoying this conversation thoroughly. Thank you. I want to highlight something that's come up twice. and that is your willingness to borrow and even steal ideas from others around the country. I think that's fantastic. There are so many initiatives around the country that fall into the category that I've been studying, innovation in healthcare delivery in the form of small but full-time teams, and so much that can be learned by sharing those insights across geography, city to city, state to state, hospital to hospital. And so I appreciate you highlighting that attitude, which is so different from entrepreneurship or innovation in the high-tech space, just to give a counterexample, which tends to be highly secretive. I've not run across secretiveness at all in healthcare, and I think that's so important. One of the first things innovators ought to be doing as they launch is finding at least one or two people somewhere in the country that's already done what they're trying to do or something similar, and learning everything that they can from that person's experience. It's unexpected that at halftime we have exactly 0 comments in the chat box and 0 raised hands. So I want to encourage, I'll carry the conversation for the full hour if you leave me no choice, but I certainly want to encourage the audience, which is big enough to go beyond what I can see on one screen now, to ask questions. And in fact, as I say that, I have a hand up from Rob Green, who, Rob, I'll get your title wrong, but it is, in general, it is involved at population health, leading the population health effort at Dartmouth-Hitchcock. Rob, go ahead and ask your question.
So thanks, Chris, and thanks, Dr. Pollack, for your talk. Great work, and many of us are struggling with similar issues. Here's my question. If the payment model does change and you get to a point where you are able to manage capitation risk more directly, what information or operations would you need to be able to do that, right? So if we just said, here's $600 per member per month for each of your high average risk patients and $6,000 for your high risk, what would you need to manage that?
Oh, a lot more data. I mean, to be honest, because we're a one-off, we're not part of a project, we're actually very data thin here, and honestly, since a year in, we're really still learning Epic. We're even data thinner in the last year. So, we do a lot of, would you be surprised if this patient died in the last 6 months? There is actually a lot of information in there. I actually think when the dust settles, we'll, someone smarter than we will manage to combine sort of, solid data, test results, dollars per member per month of actual cost with sort of the team's gut feeling. Having said that, I actually tend to think of patients in a three-dimensional grid, which I know is a really bad habit. And it's sort of this intersection of sort of medical complexity, psychosocial complexity, and actually patient activation. And that's how I think we should be segmenting patients, or we will end up segmenting patients. We do way too much on gut. It's sort of, you play your cards you're dealt is probably one of the best pieces of advice I've been given in my career. At the moment, I've been dealt a data-poor environment.
But Stuart, you do have some data that illustrates some good performance. I remember you showing me a graph about readmissions data for your clinic. Do you want to describe that graph for the audience?
So the graph is actually admissions from the emergency room, suggesting that we run at least half of less than comparable Brigham sites, which was the comparison data. I always tell people when you look at the data, you got to remember the baseline you're starting at. So I'm starting from, traditional academic medical center that, wasn't interested. I suspect if we ran that data today, it would be, we would have gotten a little bit better, but the other sites would have gotten a lot better. But it does sort of work. The problem is I can't tell, is it, which of the investments is the correct thing? Is it Caroline or is it the social worker? Is it, the way we run our access schedule? There's an outside chance it's leadership, but I have my doubts. When I go and talk, I say it's the culture, but I don't have proof of that. Whether that's actually ever going to be teasable apart, I'm not sure. I think the whole thing works.
And I think you've got some data points that are very strongly suggestive of that, and can't wait for more data for even more solid proof down the road. I want to bring up a couple of questions that came into us in advance that are specific to specific environments. And one is, Stuart, help us imagine bringing your model inside a bigger primary care operation that had departments of family medicine, departments of pediatric medicine, departments of internal medicine. Could it work in an overall larger structure like that? And what would it take to make it work?
I mean, I think it would. In my previous job, I actually ran a group of pediatricians, and I tell people that other than my own son, children sort of freak me out. Obviously, you don't need pediatrics. I'm not sure it's any different than, how do I integrate a social worker, into my team, right? I can integrate anybody into a team. I cannot tell you what the standards of quality are for social work. I expect the social work department to sort of do that. What I own is how they fit into my team, and that combination works well. I actually think it's more patient segmentation. I suspect there is more overlap between healthy pediatrics and healthy 20-year-olds than there are between healthy pediatrics and newborns that just came out of the nursery, premature babies that came out of the nursery. I think probably babies that just came out of the nursery probably overlap with my high-risk Medicare patients in what they need.
Speaking of patient segmentation, I've got one registrant who's very interested in sort of a even finer definition that might fall within what you're already doing, and that is high-risk patients that are also non-ambulatory. Do you deal with that much, and if so, what's unique about dealing with that population?
So we have a small population that actually cannot get in, and we probably don't deal with that population really well. So it's So for the true homebound population, that's actually probably the most successful Medicare ACO project out there right now. I suspect they would do better with a home care team. Unfortunately, that actually does not exist in my immediate community, so we sort of paste it together. For the patients who are just wheelchair bound, we do fine, though transportation is a story unto of itself. Caroline's biggest threat to me always is I'm going to show up one day and she's going to board a van because she's tired of working with the transportation agencies. Luckily, she has not followed through on that yet.
For those of you who are particularly interested in the homebound population, I think what Stuart mentioned is right on. It would take a very different kind of team to be excellent at that population. There is the ACO demonstration that you mentioned. There's also a team out in Oregon that's dealing with this population very directly. It is the first story on the same page, or the last now, since they're in most recent first, on the same web page on the Physician Innovator website. Underneath the story about Stuart Pollock, all the way down, the physician's name is Shannon Jackson, who's taking a pretty interesting approach to dealing with the homebound population, but quite different from what you're doing, Stuart, which I think comes back to our overall theme of matching a specially designed team to a population with very specific needs. I want to go now. Oh, go ahead.
I think one of the hardest things for us to learn, in fact, was because you're sitting here and you have this incredible team of talented people, is learning that sometimes we're not the right people. That there are several segments where you have to really say to the patient, you would be better served by this group. And it's probably, it's like 1% of the population, maybe less. But I think it took us years to get good at saying, again, we're putting a lot of resources into it and it's not working because we're just not the right people.
I've got an interesting question from Melissa Bryan in the chat window, wondering if you try to measure client experience or client satisfaction.
So we get Crest Gainey before, which they actually have not collected since Epic, since we had our EHR change. That was an organizational decision. I think it's supposed to come soon. We actually fairly consistently run 90th percentile. We're 86, then we're 94, but it's about 90th percentile. It's actually always been sort of quite good. It's interesting. If you look at our comments, when we designed the clinic, part of our hiring strategy, was for compassionate. But we clearly, what we hired for, based on the comments, is we hired for nice. So my team is made up of a lot of nice people. And one of my favorite jokes is, nice probably wouldn't be much of a differentiator in the Midwest, but in Boston, it's a fairly radical concept.
Living in the Northeast, I can understand where you're coming from. So for Alyssa and others that might be interested in the same angle, late this summer we'll have another guest on who built a primary clinic that was entirely based on the idea that if we maximize client experience, everything else will fall into place. Quite different from what you're doing, Stuart, but an interesting story, and so perhaps some of you that are interested in that hypothesis will tune in late this summer. Another question in the chat window from Margaret. How do you use the checklist that you mentioned earlier? Is that built into Epic, and are you willing to share it?
So certainly, if you drop me an email afterwards, I can, share the document. It's not that radical, but yeah, I mean, it's built in as a dot phrase in Epic, so we paste it in. Much to my disappointment, it has never been built in as something where each one's a separable data field, because you'd love to know which of the questions matter, right?
Yeah.
Do you understand what happened, or do you have food in your refrigerator? One of those matters. The question is which one matters more?
Another question from Patty just popped up related. Are you measuring? We talked about measuring client experience. How about patient activation? Is that something you're trying to measure?
So there's a wonderful tool called the patient activation measure. Unfortunately, it's not free. You actually have to pay for it. So we started measuring it on iPads and kind of got like 3 months worth of data, and then changed EHRs. It's only now are the iPads talking to the EHRs, and then the license lapse. It's life. But we're going to measure it again. The interesting question is, what are we going to do with it? And I'm not quite sure what we're doing with it, but my guess is if we're sitting in a diabetic huddle talking about an out of control diabetic, that we will learn that if they're highly activated, the interventions are different than if they have absolutely no activation. But right, I think it's one of multiple other things that we need to learn to measure in primary care.
Stuart, with an eye on the clock now and realizing we only have a little bit of time left, I'd like to move to talking a little bit about the potential growth, or if not growth, at least sustainability of what you're doing, given the financial winds, which can be hard to predict. But could you tell us a little bit, sort of the financial circumstances you're in at Partners today? And it must be very confusing, but I'll let you describe it.
Very confusing is fair. So, Massachusetts is interesting. We're basically all, Medicare accountable organizations. Pretty much every system in the state at this point. Massachusetts Blue Cross Blue Shield is, thoroughly committed to something called the HRQ, which is their ACO contract. So I live in a world of accountable care, but in a system that's still, sort of budgets and incentivizes the physicians as if we're still in fee-for-service. In many ways, it's even harder because it sort of partners to Brigham, to internal medicine, to general internal medicine, to primary care. So even, wins in ACO contracts sort of filter lower and lower and lower. It's a big issue for us. We kind of fully understand that, that actually the physicians' incentives are now more fee-for-service, volume-driven than the system's incentives. Mostly in the short term, the solution has been the budget just looks funny, and there's a big loss built into it. And I'm not a CFO, but I think we all understand that until we figure out how you actually budget in a value-based environment, that it's very hard to justify scaling an operation like this. Because obviously in a fee-for-service environment, we just look like we're hemorrhaging money left and right.
I think Don's got an interesting question that ties in nicely, and that is he's seen, and I've seen, that even with a fairly promising idea, healthcare organizations will sometimes struggle with a bunch of people who say, or just afraid it won't or it might not work. how did you find your way forward, given that you must have faced that at least a little bit, some resistance from those who thought this will never work? Go ahead.
So you have to give the organization credit. They did fund us, and actually they've now funded us for 5 years. And so part of my answer is, if you really think we are going to be in, again, the old, 10 years ago version of fee-for-service, that life is going to stay volume-driven, you're deluding yourself, right? I mean, it's clearly going to shift. And so, yes, while there's the cost of failing innovation, there's obviously a huge cost in just taking the risk that nothing is going to change and you keep getting paid the same way. And it is also very clear, because having spent a lot of my time in the capitated world before coming to Brigham in the fee-for-service world, they're very different cultures, they're very different staffing ratios. There's this whole healthcare local thing. So it's not like you can just wake up on January 1st and flip a switch and be in the value business and have any expectation you're going to succeed. But again, that's why we're a pilot, right? I mean, you just have to have the guts to pilot thing. The last thing, because I have to say this common question I get is, how in the world did you get these people to pay for this? There's a lot of benefits even in a fee-for-service system to having strong primary care, especially strong primary care taking care of complex patients. I mean, these patients bring, the hospital is very much the engine, the financial engine that drives the system. But these patients bring the hospital to a halt. You take up a highly personality disorder patient and you put them in the ICU, and all of a sudden the ICU isn't working. That's very expensive. So dealing with your super users, it allows the rest of the system to at least function.
I have a couple of thoughts for Don as well, starting with having looked at innovation in lots of industries. I can report I've never seen such a target-rich environment as innovation in healthcare delivery, but the transition and payment model is absolutely the crucial door opener that makes everything possible. There's lots of opportunity out there. There are always going to be naysayers, but if you can find at least 2 or 3 or 4 or 5 optimists within your organization, you may be able to get something small started. And the nice thing about this form of innovation is it takes the form of pretty small teams. So I think most every organization ought to be able to support a handful of pilots like Stuart is moving forward with. Stuart, I've got time for one more question for you, and you are one of the most interesting people to listen to on the topic of changes in policy or changes in payment model. You wrote an interesting article about it some time ago. The question for you is, if I had the power to make you the king, let's just go ahead and make you king, what sort of payment model would you want to have?
I think I would probably go to a better version of capitation, just because I really just want to play. Having said that, I think a lot of the Medicare fee-for-value stuff, codes that are out there, are actually working quite well for people willing to play with them. Honestly, much to my amazement. I always tell people that, saying Medicare is your friend is like saying the government is your friend. It's hard to have it come out of your mouth. But there's some good stuff out there. I actually, my gut says that we will eventually all go back down to, risk-adjusted capitation in organizations, taking care of large enough populations that it's fair. But I'm not willing to put money on that.
I'm going to leave your king's crown on for just a little bit longer and describe the physician's day from beginning to end in a primary care model that you think is optimal.
So it's interesting. I think the optimal model, I think, is actually much clearer. I think what a doctor's day looks like in 10 years is probably much clearer than how they'll get paid for it. Physicians, we like to say the physician's going to run the team. I'm not actually 100% sure that's true. I actually think it tends to stress physicians out. I think physicians are going to be the medical knowledge heart of a team. It'll probably look like my, day today minus maybe a couple less easy visits. I think, physicians will come in and they will see 8 people a day, 6 to 8 people a day. They'll be seeing, only complicated patients that basically they're protocol busters. They have too many combinations of diseases to have the protocol work. They might be doing some shared visits. Obviously, there'll be a lot of virtual stuff going on, but they'll spend a lot of time kind of walking around the practice, and the physician assistant will come in and ask a question and maybe ask them to look at a finding, and the pharmacist will have a question, and the behavioral health person will have a question, and you'll actually have to put them in touch with the pharmacist. I think you're going to spend a lot of time sort of, again, if you're the leader of the team, if you're not leading the team, just providing information. It's interesting. I think some people get stressed out of that. It's not that actually different than being a really good third-year resident. We all did this during our training. We ran these sort of teams with a lot of different people on them. We just have to get in touch with it again.
Terrific way to end, Stuart. It's been a terrific hour. I thank you for spending time with us. I thank you for the time you already spent with me leading up to today so I could learn about what you're doing and share it with others. You've been a terrific guest and a lot of fun to listen to. We're going to go ahead and say goodbye to Stuart, but Stuart, thank you very much.
Thank you so much for the opportunity.
But thank you, Stuart, and I'll go back here just to mention a couple of books. One, How Physicians Can Fix Healthcare, which has got probably 24 examples of innovations in healthcare delivery that are of the type we're focused on here. And is a sort of step-by-step managerial guide for getting the work done. And then a parable that makes all of that same insight shareable much more easily with your team, a parable called How Stella Saved the Farm. In addition to thanking Stuart, I want to thank all of my friends at Dartmouth for making this possible.